lot of things. Can anyone define ataxia for me?
Loss of coordination.
Loss of coordination, yes. So once in a neuro lecture with Dr. Peary, he asked what ataxia was, and I said, it means you're walking funny. And I was kind of trying to be funny about it, but he was like, oh, no, that's not what it means. Because it could mean, that walking funny could be anything that we just talked about. So the important thing with ataxia specifically comes from the Latin a, without, taxis is order. It's that loss of coordination, inability to make those smooth, accurate pursuits and coordinated movements between, either your gait or your arms or your trunk or whatever you're trying to do. An ataxic gait, therefore, one that is uncoordinated, unsteady, unpredictable, I think is a really helpful word to elucidate if something's truly ataxic versus a weakness or an antalgic gait, which would be a limp or something else like that. So unpredictable is just a practical word that I use in my head looking at a kid to see, like, can I really tell where their next step's going to be? And if the answer is no, that often is actual true ataxia.
What about caloric stenosis? Well, if this isn't on your boards, I don't know what's going to be on your boards, okay? And this is 3 per 1,000 live births. I mean, this is not uncommon, is it? So it's a 4.5 to 1 male to female predominance. It typically develops between 2 and 5 years of weeks of age. Symptoms are non-bilious, forceful vomiting. That makes sense, right? When we're talking bilious versus non-bilious, when we think about where anatomically this is happening, the pyloric olive is palpable in 70% of patients. I'll be honest with you. I think that 70% is published and republished probably by surgeons who are feeling this on the table before they cut them open under general anesthesia. Because in my experience, and probably in yours, you're not feeling an olive 70% of the time with a pyloric stenosis. So I just think a little bit of the literature is propagation of that, and maybe you and I would feel that more often if they were on the table under anesthesia and you could really push their abdomen really deeply. Maybe we would find 70% of the time, but this is what's in the literature. So if the olive is felt, they're ready to go to the OR, okay?
Finally, I would like to share with you some findings pertinent to the novel circumstances of the medical climate we currently find ourselves in. A recent study evaluated the early impact of COVID-19 on people with self-reported eating disorders, with participants of approximately 500 from the US and 500 from the Netherlands that were recruited via social media and filled out a survey. Some of the questions, as you can see on the slide. At the time of the study, the US had been in lockdown for approximately 3 to 5 weeks, and the Netherlands for approximately 1 month. Participants with anorexia nervosa reported increased restriction and fears about being able to find foods consistent with their meal plan. Individuals with bulimia nervosa reported increases in their binge eating episodes and their urges to binge due to having stockpiles in their home. Respondents noted marked increases in anxiety since 2019, as well as increased risk of relapse due to changes in the availability of treatment, their social supports, increased isolation, and economic factors interfering with their treatment progress. Lack of structure and increased time spent in triggering environments were also common concerns. In the US, participants were particularly anxious about not being able to exercise.
We know that racism exists. We know that it's embedded within social institutions, and those social institutions produces disparities in life conditions with threatened health because they provide the infrastructure through which social resources are distributed. We consider things such as just differential allocation of financial resources and residential segregation. Residential segregation is a distinguishing organizational characteristic of American life. And there's an extensive body of literature that shows that neighborhood poverty during adulthood as an independent risk factor for the delivery of a low birth weight infant. Beyond individual factors, community factors are strongly associated with perinatal outcomes, thought to affect outcomes through neighborhood disadvantages such as concentrated poverty, environmental stressors, limited access to health services. Racial segregation has been shown to be associated with decreased birth weight, preterm birth, and infant mortality among African American